erythroid-stimulating activity agents have been used in MDS since a long time, and we have been able to induce response by selecting patients very carefully. Lower risk MDS patients without transfusion dependency, with IPSS low and very low, are the ones who respond more frequently. We know how to select, as I mentioned, but despite these, the registration trial, because ESAs were not approved for use officially for use in MDS, are quite recent, and they were carried out not in selected patients. That's why the results of these registration trials are unsatisfactory. Nevertheless, the activity of ESAs is clear. And what was more interesting in some recent work that we performed in my group of ESIM in Italy is that the dose of ESAs to be used is not so crucial. For some years in Italy, we like to use very high dose, 80,000, up to 80,000 units per week of ESAs. But this doesn't seem to correlate with a longer survival or significantly longer survival, only for patients who were more anemic, but not as a general rule. So 30 to 40,000 seems to be as effective as 80,000. Despite the fact that we can select over transfusion dependency and lower risk with the IPSSR, we would like to be even more selective and find biomarkers predictive of response for ESAs. But again, somatic mutation that can help us for so many things did not help us for the choice of ESA treatment or not, because it is true that more than 2 somatic mutations are correlating with not such a good overall survival even after treatment with ESAs, but there are no mutations predicting specific response to these growth factors. So once again, we should keep on the clinical biomarkers and predictors that we know for the moment, while we wait for the IWG molecular classification of MDS that maybe can help us. Another important group of growth factors that can help us in treating MDS could be the one with thrombopoietic agents like eltrombopag and romiplostim. None of these agents has been approved for use in MDS, despite the fact that they are active. They do promote increase in platelets, decrease in hemorrhagic events, but did not achieve an approval by any health authorities. Eltrombopag has been approved for aplastic anemia, for the treatment of severe aplastic anemia. It's an oral drug. We have been showing a very good proportion, more than 45% of patients responding. But again, it's an experimental agent, as well as romiplostim that was evaluated earlier. The study was stopped because of an increase of bone marrow blast. It was shown that this increase in bone marrow blast was temporary. There was no risk of developing AML superior to the patients who received placebo. Nevertheless, this is also an experimental agent, and some studies are still going on to evaluate the long-term efficacy and safety of both drugs. Not frequently used, but recommended for febrile neutropenia is the use of filgrastim, G-CSF. There has been no randomized study in this sense. G-CSF is sometimes added to ESAs to improve the response and recruit some progenitors, but there are no data indicating that it is essential and its use is crucial to prevent infections. It is recommended by several guidelines to be used in patients who have severe neutropenia during MDS, receiving or not receiving treatment when they experience recurrent recurrent infections. But again, I wouldn't recommend it as a prophylactic treatment in neutropenic MDS patients.